Assalamualaikum doctors. In this video I am discussing about the video station meningitis. So first, meningitis, it is an inflammation of the meninges. Okay, inflammation of the brain, the spinal cord. Then what are the clinical features we find in meningitis? They have high grade fever, they have seizure, neck stiffness, they have eye problems, ER, photophobia, skin, there is rashes. Yes, we know petechial rash, child is toxic, maybe in ICU setting we find. So these are the features. And hearing loss is very important, memory difficulty, these are the learning disabilities, these are the complications, brain damage, these are the problems occur in meningitis. So the video can become like a child on ICU setting. There is rashes, the child convulsions present, or ICU, high grade fever, neck stiffness, Brudzinski sign, Karnik sign. These are positive showing on the video. So it is a case of meningitis. The DD we can put like sepsis, DIC, disseminated intravascular coagulations, leukemia, hemolytic urine syndrome, HAS, ITP, HSP, COVID, PIMS, pediatric inflammatory multisystem syndrome. Then non-accidental injury, dyselectrolytemia for abnormal movement, encephalitis, metabolic complications, trauma, febrile convulsions, space occupying lesions, SOL, tumor, and intracranial hemorrhage. History will ask onset, course, and durations. Anything make it better, anything make it worse. Associated with fever, high grade or low grade fever, any chills, rigor. We need to ask the child consciousness level, judgment become conscious or unconscious. The rashes, its distributions, blanchable, non-blanchable, painful, painless, itching, non-itching, child any fears, neck stiffness, irritability. Then any trauma history. For the DD we can ask first time or recurrent occur, any drug history, family history, any sick contact, general condition of the child is lethargic, diarrhea before, after and during, what happened, and any video recording of child abnormal movement. So these are the loss of consciousness, nausea, vomiting, headache, raised intracranial pressures. These are we need to ask on the history. Then we go the examination, we do admission, isolation, notification, examination under complete aseptic measures, wearing PP. Again, admission, isolation, notification, examination under complete aseptic measures, wearing PP. ABC hydration status we maintain, Glasgow Coma Scale GCS normal 15 and comatose patient is less than 8. So normal is 15, comatose patient less than 8. The best motor response is 6, best verbal response is 5, and 4 for spontaneous eye movement, eye opening. Neurological examination with Karnik sign, painful knee extensions, and Brudzinski sign, neck flexions, knee flexions. Glass test is non-blanchable. Investigations, full sepsis screening, full blood count, urine electrolyte, lactate, LDH, CRP, blood gases, blood cultures, urine cultures, and serology. So full sepsis screening we do. It is full blood count, blood sugar level, urine electrolyte, lactate, LDH, CRP, blood gases, blood cultures, urine cultures, and serology. Fundus examinations, LP within 1 hour of arrival in a hospital, and CT and MRI of the brain. What is the contraindication of lumbar punctures? Number 1, GCS is less than 9. If GCS is less than 12 or equal, discuss with the consultant. So contraindication lumbar puncture, GCS less than 9, shock, respiratory insufficiency, continuous or uncontrolled seizure, focal neurological signs, infection at the LP site, coagulopathy, known suspected, platelet count less than 40, papilloedema. So again the contraindication of lumbar puncture is GCS less than 9, patient is in shock, respiratory insufficiency, infection in the lumbar puncture site, coagulopathy, platelet count less than 40, papilloedema, then focal neurological sign, continuous uncontrolled seizure. These are the contraindication LP, and these are we do. So how can we manage? First we stabilize the patients. Okay, airway, breathing, circulations, dehydration status we maintain. Then steroid, if the age is less than if age more than 3 months and less than 12 hours from the first antibiotic. Tuberculosis non-suspected unless on TB treatment, and LP shows frankly purulent CSF WBC more than 1000 micro per liter, raised CSF WBC plus protein is more than 1 gram per liter, bacteria on gram strain. Antibiotics within 1 hour of arrival in hospitals. So antibiotic within 1 hour, with steroid we give if more than 3 months, cefotaxime or ceftriaxone in high doses. So within 1 hour we are giving cefotaxime or ceftriaxone in high doses. If age less than 3 months, we give amoxicillin IV high dose. If recently overseas or prolonged multiple antibiotic exposure over the last 3 months, we add the vancomycin. If focal neurology seizure or reduced GCS, add acyclovir, CNS dose. If there is a defined history of anaphylaxis to penicillin, give chloramphenicol. So main treatment ABCD we maintain. Tuberculosis test we send, anti-tubercular drug if needed. We give cefotaxime or ceftriaxone within 1 hour. Then, according to culture sensitivity, we give. We add, if the child is multiple exposure to antibiotic vancomycin, we add. Child less than 3 months, we add IV amoxicillin. And if there is penicillin allergy, chloramphenicol we add. And child is neurologically unconscious, seizure, neurological reduced GCS level, we give the acyclovir in CNS dose. Duration of the treatment is meningococci 7 days, Haemophilus influenza 10 days, pneumococcus and GBS 14 days, listeria and gram-negative 21 days. So meningococci 7 days, Haemophilus meningococcus 7 days, Haemophilus 10 days, Haemophilus 10 days, pneumococci and GBS 14 days, and listeria and gram-negative 21 days. Fluid restriction: normal saline plus glucose 5%, blood potassium chloride 10 mg per kg. Restriction to 80% if severe illness, hyponatremia, raised ICP. Measure urine and plasma osmolarity daily for risk of SCAD. So we give the normal saline 80% fluid restriction because SCAD is syndrome in appropriate diuretic hormone can be developed. So urine, serum chloride, hyponatremia, raised ICP, severe illness, we need to monitor the child conditions. If the patient has not improved, repeat the culture CT in 10 days. If CT normal, repeat LP. So if not improving, culture repeat, 10 days CPU do, CT normal, then do the LP again. Prophylaxis by Public Health Authority: meningococcal meningitis, ciprofloxacin single dose for all ages. Okay. Haemophilus influenza, we are giving the rifampicin once daily for 4 days for close contact less than 10 years. Pneumococcal, no prophylaxis, and follow-up hearing and developmental assessment. Hearing and developmental assessment. Now about the red flag. What are the red flag we keep in our mind in meningitis patient? What are the features? Neck stiffness, can't move his limb freely. Toxic, high-grade fever, loss of consciousness, severe headache, pararectal bleeding, hematuria, and joint pain, swelling. Thank you.